Welcome and good evening. My name is Colin Rigney. I'm one of the founders of AMSKU, and on behalf of the organization, I want to thank everybody for setting aside the time to be here with us tonight. And this is a special talk tonight. It's part of our monthly webinar series. We have another high-level presenter coming at you, and true to what we do, all things MSK ultrasound, MSK medicine. We have Dr. Buford who's going to take us through the journey of PRP, platelet-rich plasma, the how, when, and why to use it, sprinkled in with some ultrasound diagnostics and how to best deliver it using ultrasound as the image guidance. We'll do a little bit of some context and background here. I'm going to share a few slides for introduction and then give Dr. Buford the stage. So some objectives for the next 45 minutes. You're gonna have an improved understanding of the efficacy of ultrasound-guided injections from an evidence-based perspective. Whether you're new, intermediate, somewhat advanced, or maybe you're just getting started and this is part of your information gathering and diligence, I have no doubt that you're going to leave with a lot more than what you came with and something you can put into practice or take some action on like right away. And Dr. Buford is going to go through his top 5 diagnoses on ultrasound and when to use platelet-rich plasma as the intervention. Is this webinar for you? If you see patients with musculoskeletal pain, the answer is yes. And even if you don't, you're gonna come away with so much here. We have a master instructor who is going to take us through his thought process, his years of work in coming to these insights. Okay, more than insights, but really educational tools we can all use. So some introductions. This is Ryan Martin. Ryan Martin is the co-founder of AMSKU and current board director of the APTA Arizona Directors Special Interest Group. He's also a partner in modern physical therapy and sports medicine here in the Phoenix, Arizona area. And myself, I'm a consultant MSK clinician here in the Valley in Phoenix, as well as I do national as well. I'm an instructor at East Hill University. I teach radiology and imaging to the PT program, as well as some in the PA program. I, too, am a business partner in modern physical therapy and sports medicine. A little bit about us. We are a community of clinicians dedicated to excellence in advancing MSK ultrasound diagnostics into the mainstream. Our focus is helping clinicians develop the precise ultrasound techniques and diagnostic skills that lead to better outcomes. Our program is built on 3 pillars: online, customized in-person training, monthly webinars. So this is part of the experience tonight, bringing to you some real-world tools that you can use that's actionable. Our core offering is the Residency program, which is really a hands-on fellowship where clinicians who are looking to take that next step and get an extra edge with their diagnostic skills that you would need to pursue an RMSK certification. We provide a roadmap for that. We have an intense practical experience with comprehensive resources and a clear path towards reaching those objectives. And stay till the end. We do have a free course that we want to give everybody who books a call with us to learn more about our programs. And I want to just promote Dr. Buford, his Las Vegas course. Ryan and I both supported his course for years. It is, one of the most practical courses in ultrasound that if you're just getting started, or even if you're advanced or intermediate in the game, it has evolved every single year since we've been a part of it. And Don is truly somebody who, does things the right way, comes at it from the most unbiased teaching perspective possible. For 17 years in running, this course has has taught many clinicians how to become better. And we do all this to improve outcomes, diversify your skill set, which in turn can do a lot of things in your professional world. So from there, I want to introduce Dr. Buford and bring Dr. Buford up and let him go through, take us through this journey of PRP. And just so you know, everyone, he's a very gifted instructor. He's somebody who has, he really breaks things down. He could break a complex topic down to the to anybody's level of understanding of where they're at. So with that, Don, I'd like to give you the stage and give us your pearls.
God, you guys are amazing. Colin and Ryan are both longtime friends, and started with a mutual interest in sonography, and has grown just to be two of my best friends. So thank you for the invitation to participate. I'm very honored and humbled to be part of it. So they asked me to talk about 5 of the more common MSK ultrasound-guided injections. And being extremely type A and an overachiever, I came up with 10, and I couldn't get it down to 5. We've got it down to 4 body regions, but we're gonna go through this just in a way that makes it practical and designed to stimulate some thought and maybe provoke a few questions, which we're always happy to answer. So these are my disclosures. I'm going to go by these so we can save more time for videos and discussion. But Colin was already kind enough to mention course that we started way back in 2008 and is now being held twice a year in Las Vegas. The next one's coming up in January. If you're interested and you want to learn from some expert educators like Colin and Ryan, please come. It's orthosono.com. There's a couple other faculty that are in the audience as well, and we would encourage you to come and learn from them. So these are the 4 body regions where we get most of our most common injections from: the knee, the shoulder, the hip, and the elbow. I'm going to start with knee. And although there's obviously many more things we can inject, just off the top of my head, we don't have MCL on here. We don't have intraosseous on here. But what we are going to spend a little bit of time on is knee osteoarthritis and the infrapatellar or jumper's knee syndrome, which is also kind of synonymous with partial tear in the patellar tendon or patellar tendinopathy. In terms of osteoarthritis, most of the studies in regenerative medicine are focused on the mid ranges. So on the KL grading scale, we're talking about grade 2 or 3. And that's where the preponderance of patients are in these studies that are published. By far, the majority of intra-articular knee injections are done from a suprapatellar approach, and specifically from a lateral suprapatellar approach. If you ask most clinicians that have been doing knee injections, this is a preferred way for a bunch of reasons. The patient is supine, the knee is maybe slightly flexed to extended, and this allows us to do what's called an in-plane injection, meaning that needle is parallel to the face of the transducer. So this gives us our best visualization of the needle. As you see on the right, the needle is a hyperechoic line. And all we're trying to do, hopefully my pointer shows, all we're trying to do is to get that needle superior to the prefemoral fat pad here, and in that space below the quad tendon, where it's right in the subacromial space, and I'm sorry, in the prepatellar bursa. So as we get here and as we inject, we can even use a little bit of our injectate to dissect out to make sure we're in the bursa. But this is an injection that is easy to do because you get immediate visualization. You can see the tip of the needle from the skin over here laterally all the way to the injection site. The one caution would be not to inject right above the bone. You're starting from the bottom of the screen. This first white line that's kind of curved is the anterior femoral cortex. And you don't want to be within about a centimeter of that, depending on the patient's anatomy, because this is going to be fat. And this truly won't be intra-articular or in the bursa. This will be in the fat. And although the PRP or whatever you inject may eventually do some good, you're not directly getting it into the joint like you'd like to. Now, I should start by saying that no matter what location or body part we're talking about, there are at least 2 ways, and usually 3 or 4 or even 5 ways to inject the same thing. So this is not meant to say that you have to do every knee injection from a lateral suprapatellar approach. I would start with this one because this is the workhorse approach, but we all see patients that may have ill-defined knee anatomy. I'm in Dallas, Texas. That happens at least once a week. We see patients that may not have mobility. They may have flexion contractures. We need to know other ways to get a needle into the joint and still to be able to visualize it. So I would urge you, depending on wherever you're at in the learning curve, to make sure that you know at least a backup way or 2 or 3 backup ways to inject the anatomy. This image isn't showing great, but it's meant to demonstrate the same thing, a lateral suprapatellar approach. We can also inject the knee from a parapatellar approach using ultrasound guidance, and that's just something to keep in mind. Now, here's an infrapatellar tendon injection. The ultrasound image on the right is meant to show this hypoechoic defect right off the inferior pole of the patella. So this would be a bad case of jumper's knee. This is really a partial tear in the infrapatellar tendon right where it comes off the patella. And this is an area where, before rushing off to surgery, if it's only a 20%, 30%, or 40% tear, this might be an indication to try biologics, whether it's bone marrow concentrate, adipose, bone marrow, or platelet-rich plasma. That's a discussion for another talk. But the key is we have an imaging modality that allows us to see soft tissue in real time, and we can now put that needle precisely in this region and deliver the injectate right to that area of pathology. Now, you can already imagine there's 2 ways to approach this. At least we can come in plane, almost through the patellar tendon, or we can come out of plane in this image, which would be deep to the patellar tendon. So we'll show you an example of that. This blue arrow would be an example of taking a 25 gauge needle, for example, aiming for a hard stop, which I like in these injections. So the hard stop here would be the inferior pole of the patella. And then if you back that needle tip off just a little bit, you're going to be right in this partial tear, and you can inject a little bit there. Keep in mind that even with a partial tear, these tendons do not hold a lot of volume. So don't think you're going to put 6 cc's of anything in that little hole. That little hole is maybe 1/4 of an inch right there. So we put some there to stimulate a healing response. We put the rest around the patellar tendon, and usually for this tendon, because it's superficial, I put the rest on the deep surface using ultrasound guidance. So here's an example of that. Notice we've changed the transducer to now it's along the short axis of the patellar tendon here. I'm outlining the patellar tendon, and again, I apologize for the quality of the video. It just doesn't translate when we make the presentation. But you can see the hyperechoic needle, this white needle, and it's just below the patellar tendon here. And so the rest of our injectate we're placing on this inferior surface, if you will, the deep surface of the patellar tendon. There's just not a lot of room superficially, obviously. Same technique, same concepts for other tendons like the Achilles tendon that occupy a superficial position in the human body. Let's change gears for a minute. Let's talk about hip injections. We're going to focus primarily on intra-articular hip and then gluteus tendinopathy, or greater trochanteric pain syndrome, as others call it. I think John Knab's giving a talk down in Miami in a couple of weeks on this exact topic. By and large, I do my intra-articular hip injections with the patient in the supine position, and the clinical alignment is just like you see here on the left. We have a curved transducer. You can use a linear transducer. I just happen to have been taught with a curve, so I've stuck with that. And we use a spinal needle. My workhorse spinal needle is a 22 gauge spinal. And usually I'm using my spinal needles without the syringe attached just because it gives me more flexibility. So keep that in mind. It does require someone to help you put the syringe on the lower lock if you're going to do it that way. So just different ways to accomplish the same task. In general, we'd like the needle path to be just like this yellow arrow. We do not need to be up this far because we run the danger of hitting the labrum and damaging the labrum, or even hitting the chondral surface of the femoral head and damaging the cartilage on the femoral head. So we'd like to be off the weight-bearing surface of the femoral head, somewhere in this region. The joint capsule really inserts all the way down to about here. The danger in injecting way down here, though, is there's also some soft tissue and there could be some capsular thickening that makes your injection down in this region not intra-articular. So injecting up here, I think, is a little bit safer bet. You're still off the weight-bearing portion of the femoral head. And especially if we're injecting smaller volumes, we'd like to be a little bit closer to the joint to make sure that we're intra-articular before trying to wait and see if the joint capsule expands with our injection. Because if we have a low volume, that joint capsule is not going to be readily visible in expansion. So let's run the video. Again, anywhere along this femoral neck is fair game. I'd rather not be too inferior, but even here would be okay 9 times out of 100 or 99 times out of 100. So we run the video. We're going to look for our needle coming in from high on the right, which is distal, angling down this direction. I like designing these injections so that there is a bony stop if possible, because it's a safety mechanism for us. So here's the needle. The needle is hitting cortex. If you see the needle tip down here and you're not hitting bone, then you know you're out of plane in some way, shape, or form, and you need to readjust and rethink about what's happening. You can use even power Doppler to confirm that your flow is intracapsular. In a nutshell, that's how we do that injection. I think I have another example for us here. And showing similar anatomy, needle coming down. And in this example, it's a slightly larger volume that we're injecting. And so as we inject, if you look here, you'll see the hypoechoic fluid start to track up. And that's how you know you're intra-articular. See, if you watch here, see this dark joint capsule? See, it's getting distended with fluid. So that's how you know. Now, if you're only injecting 2 or 3 cc's, you may not see that. That's why I prefer to be up here just to be safe. But if you're injecting 5 cc's, 6 cc's, then you'll start to see this distension of the joint capsule. Now, there's multiple ways to inject the gluteus medius and minimus tendons. You can do them in plane with the long axis, as is shown here. You can do this in a very elegant way along the short axis, which allows you to get to the anterior facet and medial facet of the greater troch. Run the video here just for clarity on doing this long axis in plane injection. The needle's coming in from distal, just like shown here. This person is in the lateral decubitus position. As we inject here, you'll notice the gluteus medius and minimus tendons start to get highlighted by fluid. You can see with this particular machine, the fluid turns blue even, makes it even easier. And as we inject, we're starting to see the anatomy even better because they're outlining it with this injectate. And so just know that there's more than one way to inject gluteus tendinopathy. It's for sure is one of the top injections we do. We see a lot of people that come in the office with what used to be called hip bursitis, what's really probably more appropriately called hip tendinopathy or gluteus tendinopathy. Regardless of the cause, we're usually able to help if they're still symptomatic and all the other non-injectate, or less or invasive things have failed. So shoulder injections, this is near and dear to my heart as a shoulder surgeon. This is one of the videos we've used for a long time showing how we target the glenohumeral joint from a posterior approach, which really is the preferred approach. And I say that because studies have shown that even with ultrasound guidance, the accuracy from the posterior approach is greater than the accuracy from the anterior approach. So I think that this is a preferred way to do it. Now, in this little graphic, this transducer is meant to illustrate, or this outline is meant to illustrate the transducer. The red circle is meant to illustrate the injection site for the needle. So this would be an injection site where the needle would angle medial. You would see a hyperechoic needle in plane with the transducer. You could do the same injection out of plane by moving this red dot right here and injecting out of plane. I'll show you some examples of that. This would be the first example. You can see here the patient's in the lateral decubitus position, transducer here. The needle is going into the body just at the lateral edge of the transducer, and that's going to give you this image. Back. It's going to give us this image here. See the needle come down. This is the infraspinatus tendon here. We'll see the needle come down to the infraspinatus. In this example, I believe we're injecting a little bit of lidocaine superficially, but then we continue down and we inject. Here we're injecting a lot of volume. This is probably for a frozen shoulder, for example. And with this much volume, you can see the entire posterior joint capsule lift off. So that's the reason why in this example, we're starting off with a little bit of lidocaine in the posterior deltoid and superficial to the infraspinatus, because we know we're about to inject a lot of volume into the joint. Now, here's an example where we're going to do the glenohumeral joint. We're going to do the subacromial bursa. You can do this in the seated or the lateral decubitus position. I prefer the lateral decubitus position whenever possible, primarily because the patient's already laying flat. If they're going to go vasovagal, they're already in a comfortable and safe position to take a little bit of a nap while we go see somebody else and our support team helps them. Kidding. But that's why I prefer this lateral decubitus position whenever possible. If we can construct the procedures so that we're in plane, to me, that's always preferable because we get a better look at the tip of the needle most of the time. So this is a video from one of our studies where we were injecting bone marrow concentrate for patients that had partial thickness rotator cuff tears. Now, the video on the right is just showing one way to do that. I'm going to give you a better example in a minute. But so right now, let's start this video. You can see the needle coming in here. Here's a subacromial injection where we want to get deep to the deltoid. And if we're doing this in the right spot, you'll see the fluid track all the way medial and lateral. We want to leave the tip of this needle just below this white line. Really important distinction. That white line is the inferior border of the deltoid. So we're not talking a large distance or a large space here at all. If we can just see the tip of the needle, if we can get it just below that white line as we inject, that fluid ought to track along the superior border. I'm going to give you a really good example of that in a minute. So I'm going to go past this. Here's another example. Again, the needle gets just below. This is a short axis view of the rotator cuff tendon. But as we put in the needle and back off a little bit, as we start to inject, we should see the hydrodissection and we should see the fluid going into that subacromial space. So there's the tip of the needle. As we start to inject, you can see the flow. See how it starts to lift off all the way across here, all the way up the front. That's how we know we're in the right plane. If you're too superficial, you'll just see a black circle that starts to expand. You won't see this flow across the superior border of the supraspinatus tendon. Another example, lateral decubitus position. I'm going to go past this because I have something else I want to show you. This is going into a partial tear of the rotator cuff. And here's a really good example of how we target the area of tendinopathy with the needle. As we inject in this example, you can see flow all the way through, and it really kind of highlights how much damage there is in this damaged tendon. And so that's one way that we do this. And again, most of the time we're using either platelet-rich plasma or bone marrow concentrate in my practice. There's some differences between the two. In the studies that I've done, bone marrow concentrate tends to give people significantly longer symptom relief and functional improvement measured in years, as opposed to a year with platelet-rich plasma in our study. To be fair, this is a relatively low N in both studies, 25 to 30 patients. But there is a distinction and a significant distinction between the outcomes with bone marrow concentrate versus PRP for the exact same partial cuff indication. And so now again, being driven to show the latest data, this is a case we did today. So right before the webinar, I was putting this video together. This is how we get bone marrow concentrate in the office using ultrasound guidance. So it ties into using ultrasound, ties into regenerative medicine. This is a patient in the supine position. We are going to use ultrasound initially to identify the posterior iliac crest. And this is, again, with a curved transducer, just because that's the way I was brought up around the pelvis to use curved transducers. It can be done with the linear. And on the screen here, we can see this mountain. That's the posterior iliac crest. That's all we have to identify because we want our needle to come right down the 50-yard line there. Once you identify that, we know we're safe. And that little plastic tube is just meant to show the path of our Jamshidi needle and also the path of our spinal needle initially to get down to the cortex. So we've got that identified on the screen. We get that in the middle of the screen, which means it's in the middle of the transducer. We spray ethyl chloride. We move the transducer so we don't spray the ethyl chloride on the transducer. And then with a 22 gauge spinal, we go straight down to bone. We're talking, it's maybe a couple inches in most patients. This syringe has just lidocaine, or it can be a lidocaine-marcaine mix. And after putting that down in the subcutaneous tissues, we then go away for 5 minutes. Really important not to jump into the procedure. You have to give that local anesthetic time to set up. We then make a little incision with a scalpel. This is not meant to draw blood. We're not going down. Please don't go down to the posterior iliac crest with that scalpel. Just nick the skin. And then we take our jamshidi down to bone and we make sure that we're right over the crest of the posterior iliac crest, right over the apex of it. And notice I'm not using a drill. Notice I'm not using a hammer. This is today. This is real time. I've never used a hammer or a drill. Doesn't mean I don't have them in the office just in case. But what you'll see, and again, this is real time. This is not sped up. This is not spliced, or there's no George Lucas, LucasArts magic here in the post-production editing. This is real time. And the real amount of time it takes to do this with my hand to go through the cortex was 41 seconds. There we are. That was it in real time. So without a drill, without a hammer, which means we're not banging on this poor woman's pelvis, we have gotten into the posterior iliac crest. We take out the needle. We mention to the patient, you're going to feel a little bit of pressure change. And now we can go ahead and get the bone marrow aspirate. So this is all done with ultrasound guidance. We've eliminated the need for fluoroscopy. We've eliminated the need to go to a special procedure room. This is done in the room with the patient because we're set up to do it. And so now we get the bone marrow concentrate. Our particular technique isn't super important for this talk, but just know that we get 2 draws at each level, and then we go a little bit deeper. I will show you how we go a little bit deeper without getting fluoroscopy or ultrasound involved. From lots and lots of studies, we know that we just want to go a 0.5 centimeter deeper. So by holding the needle at the skin with my left hand and placing my index finger on my right hand about a 0.5 centimeter above it, I can twist down on the jamshidi until my fingers touch. When they touch, I know I've gone a 0.5 centimeter. And that's how we measure. We end up going deeper 3 successive times, drawing about 15 to 20 cc's at each level. That gives us our bone marrow concentrate. We've studied this. We've done the numbers. We've got receipts showing that our CFU counts match anyone else's published by having this single stick, multi-depth technique. And all we have left to show for it is a little stick like that that's just a steri strip to close, not even a stitch. And now here's the key. What do we do with it? Well, we go back to using ultrasound to guide this into this woman's partial thickness cup tear. And again, this is just today. She happens to be a physician. So here's her rotator cuff on the screen. Notice the clinical positioning, which is why I wanted to show you this. Patient's lateral to cube, laid back a little bit. Notice the transducer position, and there's the needle going in. Her tendinopathic region is right. See how the needle just gets right into that area very easily. And as we start to inject, you'll see the blush right here. Here we are injecting that bone marrow concentrate. Again, it's not going to hold a large volume. Do not try and put all 6 cc's here. So I'm going to slowly back the needle out. And one of the things that I've modified with our technique is I don't do a second injection for the subacromial space. I just slowly back the needle out until we hit that plane. And in a minute, you'll see why. In a minute, when I get the needle right, see, look what happens now. Now that bone marrow concentrate is filling up that subacromial space, and I haven't stuck her a second time. Before we did this, we put 6 cc's into the glenohumeral joint. So our current technique for partial cuff tears is 6 cc's in the joint, 1 cc to 2 cc's in the tendon, and 5 cc's or whatever's left in the subacromial space. So it ends up being 2 sticks, one for the joint with a posterior approach, and the second stick is what you see on the screen right here to get those last 2 locations. Biceps tendon sheath, change gears again. At least 2 ways to inject. You can do long axis or short axis. This would be a long axis approach with the patient supine. Here's an example. As you inject, you can see the injectate kind of tracking down distally and proximally. So I love this approach. We use a lot of ethyl chloride. I use very little lidocaine. For most of these injections, it's just ethyl chloride and a spinal needle. That's how we do that. Now, to do this from the other direction, we simply turn the transducer 90 degrees and you would have a short axis approach, which is shown right here in this image right here. Excuse me. Let's talk about elbow. We injected an elbow today in a professional tennis player, and I want to get to that and show you. So let's first talk about lateral elbow. Remember the superficial 50% of this ridge at the epicondyle is going to be the common extensor tendon origin. The 50% that's closest to the joint will be more of the radiocollateral ligament. This is our typical clinical setup. And again, most of the time I'm using platelet-rich plasma. We don't really have the data to use bone marrow concentrate over PRP, whether we're using single injection or multi-injection protocol. For me, this happens to be a location where I'm doing 2 or 3 injections because the data tends to support that. But just know that you can make some arguments on the number of injections in this location. The epicondyle, here's the joint. This is radial head. This ends up being a pretty superficial injection. So this is another injection where I really like to have the needle, and it doesn't have to be a spinal needle, but I like to have the needle off the syringe just for flexibility. This is the needle coming down, and here we're deep injecting the radiocollateral ligament, and then we'll back up and inject the extensor origin in just a minute. But you can see as we inject, if there's more destruction than we appreciated, it'll actually start to dissect out all the areas where there's tendinopathy. And here we are going a little bit more superficial to make sure we're getting that extensor origin here as well. And so it's just a bread and butter procedure for a sports medicine clinician who's doing these sorts of regenerative injections. And something that's easy to teach, easy to practice. And that's how we do it. Now let's go to the next. Now this is golfer's elbow, medial side of the elbow. So this is the flexor origin. And if we're trying to treat the flexors, you're going to be, again, just like on the lateral side, more superficial. If we're trying to treat the ulnar collateral ligament, we're going to be down here closer to the bone and closer to the joint, okay? Now, the tennis player we injected today, it's interesting. Actually, all of his pathology was on the medial side of his elbow, not the lateral side. And he really had an ulnar collateral ligament tear that had kind of extended into his flexor. So that's what I'm going to show you in just a minute. And here we are just turning on the Doppler just to demonstrate the increased vascularity around this tendinopathy here. That's just an example of showing how Doppler can help you make a differential diagnosis. So here's today. I'm going to go ahead and start the video. The gold arrow is just meant to point out the line of our needle here, but here's a nice view, hyperechoic needle. This is his ulnar collateral ligament down here, and it's just a lot of damage. We didn't go through the full diagnostic exam by ultrasound to show you, but now we're doing this actual procedure. This is with platelet-rich plasma. We needle it once or twice, but then we start to inject right off of the epicondyle, right off the bone. And as we do that, you should see a flush of the injectate. Now, because he also had there, you can see the injectate. You can see how it tracks all the way over to the joint. In fact, it was interesting. Some of it even went into the joint from an injection way over here. So, this is at least a grade 2 UCL injury. And we're trying everything to get him ready to play tennis again without surgery, because we know he's going to be out, 6 months to a year if he has any kind of UCL reconstruction. And the data is actually really good. If we do a series of 3 of these injections with high dose PRP, there's a really good chance, maybe call it 80%, that we can get him back to the same functional level without surgery, with a much shorter recovery time as well. Same patient, we're just redirecting the needle to be a little more superficial because he's got some flexor origin pathology as well. So again, that was today. 2 great cases today for this webinar. You can also inject the UCL, if need be, out of plane. So this is a different patient, but notice that here, instead of the needle coming from far on the left down in this path, we're coming straight down. And as we inject, you can see this grow here. Again, illustrating the destruction in this patient's ulnar collateral ligament, which normally tracks here. So this is ulnar collateral ligament. We're injecting out of plane, and you can see how this is really just a 1 or 2 cc injection, but it really demonstrates the pathology well, in my opinion. So I'm going to stop there. I'm easy to reach online, a lot of different avenues on social media, whether it's LinkedIn, Facebook. We have 2 YouTube channels, one under my name, one under Texas Orthobiologics. Our website is texasorthobiologics.com. We're even on Instagram. Only thing I don't have is some of these personal social media sites. So So please feel free to reach out. Happy to have a conversation. I'm going to stop sharing my screen if I can and turn it back over to the guys.
First off, I just wanted to say, Donnie, Dr. Buford, amazing lecture as always. I think it's really important for everybody to realize that these cases happen today, meaning this is something that Dr. Buford is doing day in and day out, and showing that he can bring in relevant, up-to-date cases to us right today. So I just want to say thank you so much, Dr. Buford, for doing that. Very educational. I want to open up the floor here. If everybody can find your Q&A, it's a little question mark on the lower taskbar. I want everybody to just kind of look down there and see if there's any questions that we have for Dr. Buford, or for any of us. Now is a great time to start asking questions. I'm going to share a little a slide of my own while people are starting to put some questions together. Let me find that here. And then everybody just make sure that we know that this is sharing. And I get some thumbs up. Okay, just so everybody knows that AMSKU, us, Colin and myself, we put this together years ago. We've put our heart and soul into this company. We've put our heart and soul into the education. We really want to get more people understanding what we do and utilizing MSK ultrasound. So we do have a 12-month program for education. And just as Colin was talking about the amazing orthosono course that Don puts on, that Dr. Buford puts on 2 times a year, even with our top tier, that is something that we include with that. So we have 30 plus CME credits that go into this. I would recommend, if you have any questions about what we do and how we do it, please book a discovery call with us. Without further ado, Colin, let's start asking these questions. That's why everyone's here.
Yeah. Thanks, Ryan. Yeah. So I had a patient asking about PRP for a potential knee meniscus tear or stem cell. I'm not very educated in the outcomes for either. What are your thoughts for orthobiologics on the meniscus?
So that's a great question. Looks like it's coming from Nathan. There's 2 distinctions for me, because I can operate on meniscus tears also. So if we stick with the non-surgical side of that question, so you've got a patient, they're diagnosed with a meniscal tear. There's a lot of things you have to think about. Is this a degenerative meniscal tear? Is it causing symptoms? And for me, maybe the most critical distinction, is it an unstable meniscal tear? Because if it's an unstable tear, it doesn't matter what any of us inject, it's not going to stabilize it. So by default, that would include bucket handle tears. By default, that would include any tear that's restricted someone's motion. So if someone is in your office and you've got an MRI documented meniscal tear and they don't have full extension or full flexion, yes, they could have arthritis, but say they don't have advanced arthritis, that's a person I would at least, if you're not doing the surgery yourself, at least get a surgical consult to see if they might be a candidate for a meniscal repair. Because in my opinion, it's not a thing we can get wrong. We get one good chance to get that fixed right. Once we determine that it's a stable pattern and symptomatic, so that would be maybe a horizontal cleavage tear, patient has full range of motion, they may have some swelling, you can look at the MRI scan and determine the anatomy where the tear is. You can target that under ultrasound guidance. It's a 25 gauge needle. I'm usually injecting at the meniscal capsular junction. And as far as the question on PRP versus bone marrow, right now the evidence supports using high dose PRP for that application. Not saying bone marrow, whether it's just bone marrow or bone marrow concentrate, doesn't work. I'm just saying that we don't have the level of data that we do with PRP. And so before I go into a more invasive procedure that's usually 3 or 4 times more expensive, I want to kind of have the receipts to show the patient this is why we're doing it. And I don't have that yet to use BMC or BMA or even adipose over PRP. So I'm using PRP in the office, again, with those disclaimers or those qualifications. It's got to be a stable tear. It's got to be a knee that has full range of motion. And if that's the case, then we'll go into the meniscus.
Awesome. Great answer.
One other quick note on that, just because it's a great question, because it brings up so many different issues. Many years ago now, we decided that we shouldn't be doing arthroscopy and doing partial meniscectomies for these degenerative meniscal tears, right? And that's become well accepted in the orthopedic surgery community. It's interesting, in the regenerative medicine community, I still see a lot of clinicians targeting those exact same degenerative tears with the regenerative injection. And the argument's the same. We have a degenerative meniscus that actually is probably not causing the symptoms. Again, this is a patient with arthritic changes. This is a degenerative meniscal tear. So I don't target those tears with anything. I would just do an intra-articular injection to treat the osteoarthritis, where we know PRP or any of the other orthobiologics has a chance to help. But the meniscal tear that I'm targeting is typically a younger patient. They do not have significant osteoarthritis. So that's a really important distinction to understand. I'm not targeting meniscal tears in KL2, KL3 osteoarthritic knees.
Great. And Don, so when you do target the meniscal tear, what's your preferred image modality of choice to guide the needle, and what's your target?
Yeah, so ultrasound obviously is the key. And for almost everything we're going to talk about in these questions tonight, if you go to my YouTube channel under Texas Orthobiologics and just search on meniscal tear PRP, you'll see videos of this. So just keep that in mind. But I'm using ultrasound. Usually the patient's supine. We have their knee kind of laid over to the side, so we have access to the medial aspect of the knee if it's a medial meniscus tear. And with the magnification and the resolution of ultrasound, we can see the meniscus, between the femur and the tibia. We can see that meniscal triangle. And especially if we have an MRI scan, we can kind of, triangulate exactly where the tear is. I'm not trying to get that needle all the way through the meniscus. I'm really just trying to get the needle at what we call the red zone, where the meniscus, if it's on the medial side, where the meniscus and the deep MCL are together, where they are, basically attached. And if we're injecting something, it's usually at that meniscocapsular junction. If we can see the meniscus clearly, we could advance that 25 gauge needle a little bit into the red-white zone, but that's it. And again, this is not a high volume. You're going to put 1, maybe 2 cc's at the meniscocapsular junction. You can back the needle out a little bit. You can treat the MCL, and then the rest of it, whatever's left over, I'm going to put and do a separate injection for an intra-articular injection to treat the rest of the knee.
Great. Thank you.
Mm-hmm.
What's your experience with fluoroscopy and shoulder injections?
So again, I did the residency in orthopedic surgery and at a trauma hospital. So if I had called my 5th year and said, hey, I need to get to the fluoro suite to do this shoulder injection, they not only would they have kicked me out of the program, they probably would beat me up on the way out. So I've literally not done any significant fluoroscopic guided shoulder injections. It's always been palpation until I got smart and got ultrasound, and now I can do ultrasound guided. So I'm not saying it's wrong. I'm just saying that I don't have any experience with it. Certainly you can do it. I just think the resolution and the advantage of seeing soft tissues with ultrasound is so significant that I can't think of a situation. I mean, there's always a situation, but I can't think of a really great situation where I would rather have fluoro over ultrasound.
Right. And what is the platelet dosing that you are targeting for your intra-articular PRP versus tendinopathy? And this question is from James.
Yeah, great question, James. So in general, with the time we have, I'm just giving you just a general answer. One of the studies, I was in a team that published last year. We looked at this question for soft tissue indications for PRP. And to summarize briefly, what we found was that 9 out of 9 studies that had platelet doses below 3.5 billion platelets showed 0 benefit versus placebo or control for soft tissue applications. And that included tendinopathies, that included ligament applications, included muscle applications. So the take-home message from that was, if you're below 3.5 billion, pretty good chance you're not helping at all. In that same study, 9 out of 11 papers that were above 3.5 billion showed statistically significant benefit versus placebo or control for the same soft tissue applications. So Achilles, gluteus, medial lateral tennis, elbow tendinopathy, all these indications. My message would be get at least above 3.5 billion platelets for soft tissue indications, preferably closer to 5, because the studies that have quantified higher doses have shown even better outcomes versus studies that were lower doses. So that's my answer for soft tissue. for the joints, for intra-articular applications, at least above 5 billion is where I'd like to be. We've got two kind of landmark studies for knee OA, for example. One is out of India from Dr. Bansal, which was a study that's widely quoted now, where he documented a dose of 10 billion platelets in a single injection, and his patients did well for at least a year. He wrote the paper up at a year, and they were still doing well, the vast majority of them. There's another study out of China by a doctor named Dr. Chu, who did a slightly different protocol at a lower dose. So he did a dose of 4 billion platelets weekly for 3 weeks. So the total dose was 12 billion, but it was 3 injections at that, each injection being a lower dose. So those patients in his study did well for 4 years. And, hard to believe that you're doing something for 3 weeks and people show benefit 4 years, but that's what he documented. Both of those studies were level 1 double-blinded studies. So you can support multiple injections. You can support high dose single injection as well. But the key is you want to be a higher dose. Once you make that leap and believe that data, you then have to look at your PRP protocol, because if you don't have the ability to check the dose on every injection, then you want to make sure you vet your PRP kit so that you know that for a certain blood draw and for a certain minimal platelet count, call it the lowest normal platelet count, that you're always going to be above the platelet doses that you want. And that gets into topics we talk about at the meeting or talk about online, or there's videos of talking about this. But the key is, if you had to remember a number, I'd say get to 5 billion for soft tissue, get to 8, 9, 10 billion for knees, whether it's single or multi-injection. And that'll keep you safe and get good results for your patients most of the time.
Great. Hope that was helpful, James. That was a pretty good question, a very thorough response. So with the time we have, we got a lot of questions coming in.
Mm-hmm.
Ariana, hi Ariana. How do you get practical experience to use ultrasound for injections?
How do you get practical experience? So, I started just from an atlas, because the reason we started our course was because there wasn't a course. So I started just with atlases and with whatever I could find online. I think that's a good start. If you go to Amazon, or if you talk to Colin or Ryan or Ariana or myself offline, we'll give you lots of tips on textbooks that are out there. All of them are available on Amazon nowadays. And so you have to start there. But really, this is a technique, or this is an imaging modality that you have to practice like anything else. And it really helps to have a mentor, or to have somebody to kind of look over your shoulder as you do this hands-on. It's operator dependent, but that doesn't mean you should be scared to start and to try, because everything in life we do is operator dependent. and everything that we are good at in life, we're good at it because we practiced at some level. So it's just a matter of you drinking the Kool-Aid that this is going to help you clinically and help your patients clinically, and then starting to find the textbooks, the online media. You start to find these online courses that Colin and Ryan have put together that are fantastic, that did not exist when I was learning. I wish they did. And you start to take advantage of those things. You'll notice that Colin and Ryan and I and Ariana have all started to work together in various ways in this business, with ultrasound, with regenerative medicine, with the business of orthobiologics. And they all tie together. You have to have all these things integrated in your practice to deliver the best care for these patients, in my opinion.
Absolutely. Yeah. Repetition, and guided repetition.
Yeah. Practice. If you're just practicing something poorly, you're not going to get better at it. Right. It's structured, good practice under an expert eye.
Yep. The feedback is what really matters.
Mm-hmm.
This is a good one. And with BMAC for the shoulder, when do you expect the patient to have a decrease in painful symptoms? And maybe it doesn't say intra-articular or tendinopathy, but maybe just what do you tell the patient when you're talking about that, Don?
Well, in general, if we talk about intra-articular in general, and this is really whether it's BMAC or PRP, I tell people 2 weeks. It's a good benchmark. It's easy to remember. I tell them it's an average. So if somebody gets to 15 days, they're not blowing up my phone. But I tell them 2 weeks on average, you ought to start to notice some changes. Usually for me, regardless of the orthobiologic, by 3 months, the results pretty much baked in. Okay. So, and what I mean by that is if somebody is cruising along for 3 months with no improvement, it's rare that at the fourth month they suddenly get better. Usually there's a graduated improvement that starts around 2 weeks. Um, it's about the same for tendinopathies. Okay. So with tendinopathies, I tell people the same. They're going to be a little bit more sore at the beginning because it's impossible to put something in a tendon without creating some discomfort for a little bit of time. But once that wears off, and I'm speaking from personal experience on this front as well, usually by the second month, maybe the third, depending on the amount of damage, they should be able to do most things and have noticeable improvement over their pre-injection state.
Good. Hope that was helpful, Brett. Let's see.
Quick question from Jonathan about the BMC with the ultrasound-guided technique that I have. He's exactly right. In the video that we did from today, the technique that we validated and wrote up and published and that we've now done, I don't want to say 1,000, hundreds and hundreds of times, including 40 live demos now, if you guys can believe that. It's straight up and down. And I realized the iliac crest is actually curved, maybe 25 degrees when we looked at a ton of CT scans. But the reason I go straight up and down on the PSIS is because it gives me 4.5 centimeters of space, and it's a lot easier to teach. So it's a lot easier for me to teach people to be straight up and down than to angle 25 degrees. As soon as someone hits, intermediate or expert, if they want to angle a little bit, there's nothing wrong with that. I sure wouldn't angle medial. You don't want to ever do that. But straight up and down, you have plenty of room to be safe. Our technique, you only have to go in about 2.5 centimeters total. So there's a 50%, actually it's 100% safety margin. And that's why I teach it that way, Jonathan, just because it gives me a reproducible way to teach where if someone's just getting started on the learning curve, I know I can keep them safe by saying straight up and down. And because none of these needles have the kind of level that I would love for them to have, where if you get to 25 degrees, you have a little bubble that shows you're at 25 degrees. None of them have that. Otherwise, I would teach that because then they would have visual confirmation. But otherwise, it's too hard for us as humans to agree on what 25 degrees or 22 degrees looks like.
Sure. Typical return to tennis elbow for your PRPs?
About the same, depending on how long they've been symptomatic and how much damage they have. I tell them they're going to start about 2 weeks. And then, obviously the rehab that we don't talk about enough is key also. It's graded, it's in phases to get their strength back, to get their motion back. So, I tell people 3 months. I'm purposely conservative. Although they may start drilling before that, but I tell them 3 months, depending on what they have to get back to.
Sure. Any danger of putting too many platelets in?
Not yet. We don't have a study that shows we can be too high on the dose, to my knowledge. So keep ramping it up. Just keep good data.
That was from James. Okay, Kenneth, how much and what kind of local anesthetic do you typically use?
So I try not to use any local anesthetic, with the exception that if the anesthetic is not going to be where you're putting in your orthobiologic, you're okay. So you saw me use local anesthetic when I was getting bone marrow because the bone marrow is coming out of the bone and the local anesthetic is nowhere inside the bone. I don't use local anesthetic at the elbow because the local anesthetic would be right where I'm injecting. So I prefer not to. If you're going to raise a little 0.5 cc or 1 cc skin wheel, I probably wouldn't argue with that. But in my experience, ethyl chloride is so fast and so easy. And we haven't lost anyone yet just using ethyl chloride for these more superficial locations. So I typically do not use the local anesthetic. A lot of that's understand that a lot of that's based on bench data. It's not based on a clinical study. So I get it. It's not like I have a study where I can say that with local anesthetic, our results are 20% worse. And then we'd have something to show. We don't have that. What we have is in vivo studies showing that local anesthetic is not good for PRP. It's not good for cellular content. And so that led to us saying, don't use PRP anywhere, or don't use local anesthetic anywhere we're using PRP or cells. But there isn't really a great clinical study, to my knowledge, with and without. It's just easy not to use it.
Yeah. And last question, timing between steroid injections and regen options.
Great question. It'll vary depending on who you ask. If we're talking about intra-articular, I would love to get about a month away from an intra-articular steroid injection before doing a PRP injection. I would love to get the same time frame away from even a soft tissue injection, because it's usually low hanging fruit. It's easy to just have someone, wait for a month. Now, all of us will have patients that travel to see us from long distance. It's hard to turn someone away that's just driven 3.5 hours. So if you're in that situation and it's been, 3 weeks, 2 weeks, am I going to send them away to come back in 2 weeks? Honestly, I'm compassionate, and I haven't seen a drop off in my outcomes. But here's the trick for me. I will raise the dose. If I was going to draw 60 cc's, I will draw 120 cc's of blood. Okay. In fact, I'm doing that more often than I'm not anyway. But if there's any question about the efficacy of the procedure or the PRP, then because we don't have a study showing we can be too high, we have lots of studies showing that the higher doses lead to better outcomes. If someone's had a steroid shot 3 weeks ago, I'm very likely going to increase my blood draw to get a higher platelet dose.
And last one, I think this could be fairly quick. Use avoidance of NSAIDs pre-post PRP injection and effective prior steroid injections.
So again, as long as we get enough time in between the steroid and the orthobiological procedure, I think we're okay. NSAIDs are interesting. There's a paper, the author is escaping right now, but basically, if you can get a week away from your NSAIDs, you're going to be okay. And there are some NSAIDs where you don't even need to wait that long. But if you want to be safe, I would say a week. For sure, 2 weeks is plenty. But who asked that question? Bob or Robert? Yeah, if Robert, hit me up and I'll send you the actual link. There's a paper that just came out about that within the last year. Ariana or one of you guys may actually have it. But just know that I try and wait a week. Again, if someone was taking something on a regular basis, I think that makes sense. If someone answers that question with, well, I take Motrin every once in a while, I'm not even going to worry about it.
Great. Awesome. Well, Ryan, anything else to add?
Yeah, just real quickly. I just want everybody on here. I see that we haven't really had a drop off of people, so that's great. That means we're providing something that people want to listen to. We're hopefully adding value. I know there's one more question on there. Maybe we can get to that one, but for everybody on here, you can see the bubble that says TA. That's Churiro. She's the one that makes a lot of this possible. So if everybody can give a round of applause for Churiro for making this happen, I never want to go without saying thank you so much to her for making these happen. Oh, look at that. All the hands up for you, Churiro. Did we want to hit this last one from Madhur Chada? There's one that has to do with orthobiologics and adhesive capsulitis. Do you want to hit that? And then I think we can call it a night, everybody.
Yeah, I was just answering just to make sure. So I typically don't add PRP to a hydrodilatation for adhesive capsulitis. I just do the normal saline and use the count on the volume to disrupt the joint capsule. For me, at least the way I was brought up and what I've seen in my practice, both in the office and confirmed at arthroscopy, is by and large, the primary pathology that I see, and I realize there's multiple pathways, but they all seem to end with that capsule being thickened. And when I say thickened, that posterior capsule, which may only be a millimeter normally, when you look at it under the camera, is 10 times thicker in somebody with adhesive capsulitis, in addition to being inflamed and looking very angry. And so when we do things surgically to help people with frozen shoulder, it's all designed to break up that really thick capsule. And so when I'm doing an in-office hydrodilatation without the manipulation, without the capsular release with a pair of scissors, I'm trying to put in enough volume to stretch that so much where if that capsule breaks, that's actually a good thing. That's what I do in a manipulation or a capsular release anyway. I've had people call me and say, I was doing a dilatation, I got really scared because there was kind of a pop and then all the fluid went away. Well, I'm like, yeah, you ruptured the capsule. That's actually, they will do great. And to a man or a woman, they've always reported back that the patient actually felt even better. So just keep that in mind. I don't use PRP just because there isn't really a great study, in my opinion. The PRP adds to the outcome. And PRP is not free, so that's where I'm at with that. Again, I try and stay evidence-based and the results with the hydrodilatation that's well done are really good without an orthobiologic.
Yeah, fantastic answer. everybody, I just want to say thank you again for everybody showing up. Dr. Buford, everyone, this has just been a pleasure for me listening to him every single time. I love having you here. It's great to have you as a colleague, and definitely great having you as a friend. So thank you so much for coming on with us tonight. All these rounds of applause, this goes out to everybody that's put this together, for Dr. Buford, for Colin, for everybody that's been here. Give yourselves a round of applause for being on this journey with us. I will be signing out. I am out in Costa Rica right now, so internet is a little spotty. So thank you for bearing, for being with me on that one. So I am signing out, everybody. Thank you so much for everyone coming out. Any questions, comments, or concerns, reach out to us on those links that we have. Thanks, everyone.
All right, everyone. Good night. Thank you.